Good morning, everyone. It is my pleasure to welcome you to our seminar today, Taking Stock of HIV Implementation Research, EHE Findings, and CHESHIRE Network Services. My name is Dennis Lee. I'm an assistant professor at Northwestern University and part of the NIH-funded HIV Implementation Science Coordination Initiative. And I will be one of the moderators for today's event. We have a really packed agenda today, so I'm going to be rushing through these intro slides very quickly, but please allow me to take a minute to cover some important logistical information. First, I wanted to remind everyone that this is a hybrid meeting. Thank you to those in the room who, from NIH and HRSA who are able to join in person. Thanks to the several hundred participants or registrants online for joining. We have coverage from across the continental US, from Providence to Miami, to El Paso, to San Diego and Seattle. We know it's really early for you on the West Coast. And then to those of you joining from Burkina Faso, Zambia, and Nigeria, good afternoon. For those online, please feel free to enter questions into the chat throughout the day. NIH staff will be moderating those questions, and we will try to answer as many as we can in real time. To all attendees, please be aware that the meeting is being recorded, and we are looking into the options for sharing it out. Second, those in person are invited to join us for some informal networking over lunch. And if you would like to do so, please place your lunch orders by using the QR code on your table by 9:45. Very important information. All right, now I'm going to quickly provide an overview of today's meeting. For time's sake, we'll not do introductions of speakers across the morning, but you'll find everyone's names in the printed and online agendas. And I promise that we are all very friendly and approachable people, so if you would like to connect with us after the seminar, please feel free to do so. First up, we will have opening remarks from Dr. Geri Donenberg, whom I will further introduce in a second. Brian Mustansky and Nanette Benbow, co-directors of the HIV ISCI, Implementation Science Coordination Initiative with me, will tell you all about the work that EHE and this network have done so far. Directors from each of the 8 implementation science hubs will give us a rapid-fire tour of all the incredible services and activities that they have to offer. Debbie Humphreys, co-director of the Yale Ready Hub and lead of our previous evaluation efforts, will go deeper into our impact thus far. Cherie Schwartz, co-director of the Johns Hopkins HIV IS Hub, will lead of our multi-site research efforts, will present results from our first multi-site study on Rapid Start. And then we'll end the live stream portion with a moderated question and answer session. For those online, again, please feel free to add questions throughout the morning. For those in the room, we will continue discussions after a short break, followed by our informal networking lunch. Reminder, please place your lunch orders by 9:45 a.m. All right, without further ado, and for time's sake, let me introduce our first speaker, Dr. Geri Donenberg, who will give the opening remarks. Dr. Donenberg is the Associate Director for AIDS Research and Director of the Office of AIDS Research at the National Institutes of Health. Working in close collaboration with NIH institutes and centers, Dr. Donenberg leads OAR in coordinating the NIH HIV research program to achieve pandemic control, prevent new transmissions, and improve the health of people with HIV. Dr. Donenberg brings to NIH more than 25 years of HIV research experience across the HIV continuum, and an emphasis on health disparities and global impact. Dr. Donenberg joined OAR from the University of Illinois in Chicago, which is where we are based as well, where she served as Professor of Medicine and Psychology, Associate Dean of Research in the School of Public Health, Director of the Healthy Youths Program, and founded and directed the Center for Dissemination and Implementation Science and Health Disparities. Without further ado, Dr. Donenberg.
Thank you for such a nice introduction. Good morning, everybody. I want to thank the organizers for inviting me to speak today and share what OAR, my office, is doing to accelerate HIV and implementation science research here at the federal government in the NIH. And I think for all of us just coming off of the conference, the D&I conference, there's a lot of interest in this and it's very exciting. Go in the way. Oops.
Stand by. Sorry about that.
No. I heard someone say yesterday when there were technical difficulties, being someone who works a lot in low resource settings, I'm used to this, so I think I'll just keep going. And when they catch up with me, they'll catch up with me. So for those of you who are not as familiar with the Office of AIDS Research, we are really the coordinating body across the whole NIH with regard to HIV-related research. And we support a very broad and complex portfolio, which is in recognition of the very nature of HIV. So OAR, it sits within the office of the director, and it's a kind of a big name called Division of Program Coordination, Planning, and Strategic Initiatives, which we call DPCIPSI. And as the coordinating office, we don't directly issue grants awards, but we actually collaborate with the NIH institutes who actually do the grant awarding themselves. But as you know, we allocate, there's a separate allocation for the HIV/AIDS funding that was mandated by Congress within the NIH budget. And our office's function is to contribute to coordinate the distribution of those funds across the NIH. And we currently distribute funds to 20 different institutes and centers. And in fiscal year 2025, we had a budget of $3.29 billion, which supported 3,800 awards across the NIH. Gonna catch up with me? This next slide is actually kind of important because I'd like you to see it. Okay, so there, thank you. I'm very pleased to say that HIV is a priority of this director, the NIH director, and so you'll see this was a quote of his, ending in his list of priorities. Ending the HIV epidemic in the United States remains a key priority, and you can read the rest of this, and probably you have already, but it basically emphasizes the need to use implementation science to understand how best to get what works to the people that most need it. Oops. Next, is that the next slide? Oh, okay. That's interesting. I think my things are out of order, or yours are out of order. Sorry about that. In any case, this clearly demonstrates that all, and this isn't something you don't know, that all Americans are not benefiting, right? And I'm specifically speaking about Americans because that's the priority of this administration, but it's not to ignore the importance of global health settings. So keep that in mind, but these were recent data from the CDC that basically shows that despite these the interventions that we currently have, we have about 13% out of every 100 Americans who have HIV don't know that they have it, right? And then 34% weren't receiving care or treatment, and then 43% of those who were diagnosed weren't virally suppressed. And so I think it's important to keep those numbers in mind as we argue in favor of moving to the next phase of the epidemic. I also want to highlight, and I don't think I have a slide for this, but maybe I do. Yeah, no, there it goes. I think these were out of order, but anyway, that while disparities exist, we're seeing that all communities are affected by HIV. And I think this is going to be a very important point for the current administration, that while this group and we all recognize the importance of HIV among gay and bisexual men, we also see that nearly 1 in 5 new diagnoses in the US are among young people, and about 1 in 4 are among women. And so, and it's not up here, but about 1 in 4 were acquired through heterosexual activity. And again, you know, reducing stigma is a critical piece of this, and helping people recognize that while there are groups that are disproportionately affected by HIV, that all of us are affected by HIV. So I don't know, many of you might have seen this, but I really like this slide because not only does it point out to everyone in this room who's familiar with this, that there's this serious gap, right, between when something is discovered and when it gets into practice. And people, I've heard 14 years, 17 years. Essentially, we wait a long time from the time of a discovery till it makes it into practice. And where we are today, we have an opportunity to really clarify what the miracle is that happens in between the discovery and when it gets to practice. And so for us, that's super exciting because this director is very eager to address these issues. This is a framework I really like by Sarit Golub, just to call out when we think about implementation science for people who are a little bit less familiar, that we're talking about multiple levels of influence that affect implementation. It could be who can do these methods. It can be who we're trying to impact, what we're trying to impact. It could be the outcomes, could be strategies. And she has a really nice paper that we cite here that I would refer those of you who are interested in learning more about this particular framework to understand the bigger picture in many ways of implementation science. So our office has the exciting ability to stimulate innovative science. And we do that in a number of ways, and we will be doing it around implementation science and HIV. We've started to do that, and we have started to generate a program that's broader across the whole NIH. This is something I've been specifically tasked to do. And so we use symposia, we use workshops, publications. We will be putting out a request for information about what you as the community of either extramural researchers or federal folks, anybody who's online, believes are the next important questions around HIV and implementation science. And then we also get to, as you know, fund grants and contracts and use interesting new mechanisms like challenge awards. How many of you have heard the term highlighted topics? Raise your hand. Oh, you guys are, maybe that's because you were just at the D&I conference. No one that we did a workshop with folks around writing D&I grants, and there wasn't a single person in the room who heard of highlighted topics. The reason these are very important and you should be aware of them is because the NIH is kind of doing away with NOFOs as much as they can. They're going to have a very limited number of NOFOs, and what they really want to see is investigator-led science. So rather than having NIH really dictate what you should be applying for and what your grants should be focused on, they would like to see more, they would like to see you initiate those ideas, and that they feel the scientists have the best ideas rather than necessarily NIH folks. So what they have created is this section on the website called Highlighted Topics, and that is to give you an idea of what types of research is of interest to the NIH and specifically to the different institutes. And what you'll see is, you'll see sort of a description of the highlighted topic, and then you'll see the institutes that have signed on to that. Much like you might have seen a NOCI or a NOFO, and it'll tell you, sometimes the institutes will have a little paragraph about why they're specifically interested in that highlighted topic. And we're very delighted to say that our first highlighted topic has come to pass and been published on the website, which you see here. We hope to have more in the future as well. And if you're interested in browsing other highlighted topics, you should just go to this website and you can see some of the other highlighted topics that have been approved and published. So for my last slide, I just want to preview a little bit of the upcoming NIH-wide HIV and HIV-related strategic plan. It's now our time to do that. It's for 26 to 30. It's under review. It passed review at the DPCIPSI level. It's under review with the executive sec. But I would like to just highlight for you that we do and will continue to support a full comprehensive research portfolio. I know there's a lot of worry about that, and there's a lot of concern, and there's a lot of talk. We absolutely are continuing to support the full range of the portfolio. What we are doing is we're pivoting so that we see more funding and more effort in implementation science than we have seen before. And the reason that's important is if you look, we took a look and did a portfolio analysis of the HIV and implementation science funded grants for 2024 at least. Those were the data we had at the time. And a very small $216 million out of $3.3 billion were spent at the cross-section of HIV and implementation science. So there is absolutely room to grow. My humble opinion, it must grow. I think we have an opportunity. We have tools that work. We got to get them to the people who need them. I know I'm preaching to the choir here because you're all here, but please know that we are definitely emphasizing, fundamental research, therapeutics, all of that. But what you will notice, the structure of the strategic plan has changed a little bit. So implementation science features more prominently at the top, but it's still, and we've added an operational efficiency goal, which really has to do with capacity building and training. So that we hope covers all of the areas related to implementation science, fundamental research, and intervention research. So I am going to end there and thank you for your time. I'm happy, I don't know if there should be questions. I'm happy to take questions. I probably can't stay for the whole event, but I'm happy to answer anything that questions people might have. Okay, thanks.
Good morning. Thank you so much, Geri. That was really inspiring. And I'm going to share this part of the presentation with Brian Mustansky to talk a little bit about EHE findings, accomplishments, and progress since 2018, actually. Next. Oh, I do it. Okay, so we're going to take a deep breath and a step back and kind of look at past, present, and future. We just got a really inspiring talk about what the future is going to bring. So I just want to tell you a little bit about kind of the history of the idea and creation of creating implementation science resources, describe some of the resources offered by ISCI and offered by the hubs, which we refer to as CHESHIRE, how to access those resources, some metrics of growth, of which there really there's been a lot of growth in this field, and future directions. So a little bit about the history. It started in 2018. Steph Barral from Hopkins and us at Northwestern said, well, let's have a workshop. Let's think about what the status of implementation science is in HIV. And we know implementation science did indeed exist in HIV. That was not the beginning, but there was definitely room for growth, we thought. And we convened a planning committee to think about how we wanted to approach both the workshop and thinking about future directions. There were 23 members on the committee, and we had people from federal agencies, NIH, HRSA, CDC, USAID, and a foundation. And what we wanted to achieve in that workshop was, leverage implementation science expertise among HIV investigators who did have experience in doing that, and synthesize the state of the art, what was in existence at the time, identify challenges and potential solutions to conducting HIV implementation research in academic practice collaborations, and to disseminate findings from the workshops and try to map out a future direction. So we had the workshop in Chicago in 2018, catalyzing HIV implementation science through methodological innovation and multi-sector partnerships. And in preparation for the conference, we wanted to kind of understand what is the state of implementation science at large in the HIV field, particularly in science. So we conducted an informal survey with the CFARs and ARCs at the time, and we asked them, does your CFAR have cores that provide dissemination implementation services or consultations? 40% said yes, more than half said no. Then we asked them if they had a scientific working group that focused on dissemination implementation science. 42 said yes, 45 said no, and 13 were unsure. And then we asked if they provided D&I research training workforce or development. 36% said yes, similar proportion said no, and a fair amount of unsure. And this unsure was just implementation science wasn't on everybody's radar. So yeah, maybe it exists, but I'm not quite sure. The other thing we did was let's go back and take a look. Let's look from 2013 to when we did this, to 2018, to identify what has been funded, what studies exist in HIV implementation science. And really what we wanted to do was to identify the proportion and characteristics of HIV-related implementation research studies funded by NIH. NIH Reporter was our source. And we wanted to establish a baseline and then monitor progress and evaluate impact. We're doing some of that today, and I would invite anybody to redo this today. We've got a really good baseline. So what we looked at is we defined HIV research as studies that measure an HIV outcome related to one of the prevention or care continuums. And then we defined implementation-related research as studies that evaluate the use of strategies to integrate interventions in real-world settings, and that was a definition used by NIH in 2013. And what we found, we identified 594 such HIV studies, and we found that 36% of them met the NIH-defined the definition of implementation research. And then if we looked at those that were specifically looking at implementation research outcomes, only 18% of the studies met that qualification. And 13% of those that were implementation-related studies mentioned the use of an implementation science framework, model, or theory. So the key take-home, there were many, and I can tell you it was great to see everybody, and the passion and excitement in the room was huge. Because as kind of the landscape manuscript showed and our meetings, there was implementation science was relatively new in the field, and there's need for ongoing support and guidance to CFAR-affiliated researchers interested in effective integration of HIV-related implementation science methods. So that was kind of our charge, and after that, the planning meeting, many of which of you are here today or online, had a series of future steps. What is it that we want to achieve? And as part of that, we created the Inter-CFAR Implementation Science Working Group, which we are now in conversations about on a 2.0. So we really had kind of a charge. We'd kind of mapped out what we thought future directions might be. And I think this might have helped inform a little bit. What then, with the coming out of the EHE initiative, all federal agencies contributed. NIH, I think quite visionary, decided to bolster funding for implementation of research in high burden US areas. And the task was fund researchers to conduct planning projects, to form partnerships to address local high priority gaps. And it was the partnerships was absolutely key. Researchers had to identify and design targeted implementation research projects that were of local relevance. So current, bringing you back to present times, a bit of a timeline. So in the last 8 years, from the summit to today, there's been huge, huge progress. So starting in 2019 with the funding of NIH, the coordination hub was funded and the first 65 EHE projects were funded. By 2022, an additional 4 hubs were funded to provide implementation science support and coordination. And then in 2022, and then 4 more hubs were funded. And as of 2025, there are 8 funded hubs and a coordination center. So over these 8 years, we have a coordinating center, 9 US hubs, 5 national meetings have been had, and over 260 EHE supplements and our series grants have been funded. So collectively, and everything we do is collective, we only move the needle that way, between ISCI and the hubs, we would, our pathway to ending the HIV epidemic is let's synthesize the literature. What's being done? What do we know? What are research gaps? Let's provide coordination and implementation science support to projects. Let's conduct multi-site research to really be able to understand fully contexts and implementation strategies for scale up. All of that to create generalizable knowledge and through dissemination and implementation scale up and the HIV epidemic. I'm briefly going to describe what the ISCI has done, and then we're going to describe what the hubs have been doing. So I will take the ISCI part. I'd like to thank our implementation science team, really stellar, couldn't do that without them, a series of great folks and dedicated folks at the table. Again, as Dennis mentioned, Brian, Dennis and I lead this effort. And our approach to support and coordination is through a number of activities, the systematic reviews accessible through an interactive dashboard, identifying best practice implementation strategies, creating implementation science tools for others to use, trying to identify how to have shared data elements and coordination, dissemination through JADE special issues, websites and newsletters, and offering training opportunities. Just briefly, if you all look, our dashboard will be up soon. We're really revamping it, and it'll be out in 2026. But to date, with PrEP and HIV testing and linkage, we've identified 495 articles. And if we just think of determinants, there are 3,500 determinants, so no problem. We can deal with that quickly. And as part of, this is then a database that is really for public use. All the studies are there, a lot of information is there, and kind of ancillary publications from the systematic review. We have published 9 manuscripts on determinant strategies and adjunctive interventions, addressing various pillars and populations, and are in the process of conducting some on the way, one a scoping review in adolescents, and the other on long-acting injectables. Thus far, in our very preliminary scoping review, we've identified 19 articles that are on long-acting PrEP and 24 articles on long-acting ART. In the terms of dissemination, I invite you all to go to our website. There's a lot of information there that's tailored both for researchers and practitioners. And we have an interchange newsletter where anybody who wants to share anything related to implementation science kids send it our way. We will add it to the newsletter, and that comes out every 2 weeks. Please sign up if you're not a part of that already. Another dissemination that we have are through, we've put out 2 JADE supplements. One came out in 2022. It highlighted findings on implementation science work from 2009 to 2012. That included EHE projects and other larger domestic HIV implementation research studies. 27 articles were in that issue. And then in 2025, we took a slightly different approach, which was let's have an explicit call for collaborative projects among EHE projects. Again, thinking about that, creating generalizable knowledge. So we asked EHE projects to work together and write these collaborative articles. There are 25 articles representing 118 EHE projects out of the 248 that were funded at the time, and covering over 40 jurisdictions. So really, I think a worthwhile effort and definitely something worth continuing. As you know, back in our workshop, you know, we wanted to identify best practice strategies. We're in the process of doing that now, and we thought in order to do that, well, we needed some criteria to identify what was, you know, the evidence level of implementation strategies. So Dr. Virginia McKay and others worked on trying to identify those criteria, and then we applied those criteria to the PrEP strategies that we had identified through our scoping review. And then, well, we don't want that to sit on the shelf. We want to create dissemination material that is readily available. Implementation strategies on the shelf are just not going to move the needle. So those who are implementing need to know about this. And we did a series of input sessions to identify what was the best way to disseminate this information. We have fact sheets. We have a big, you know, a big guide for those who want it, and we have a video kind of explaining it. So targeting different audiences. We released a number of implementation science tools, and these were informed by what would be really helpful for EHE projects to have and what might help standardize to a certain extent what folks are doing, so we can again create generalizable knowledge. So we have the interactive longitudinal implementation strategy tracking system that was developed by our colleague J.D. Smith and others. An interactive implementation research logic model. That logic model, known as IRLM, has been heavily used and modified. All of these are living documents as we learn more. And the implementation outcomes crosswalk, something to guide people on how you might want to think and approach and define your implementation outcomes. And I think there's now some more work recently released by Dr. Borsica-Rabin. So I just want to end ISCI really highlighting not really us, but the projects. At the end of the day, they are at the heart of this. They conducted this research and really, I think, have contributed significantly to scaling up implementation science and impacting communities. So of the 260 EHE projects, 51 of them are in jurisdictions represented by the EHE. 195 of them focus on HIV prevention. 61 of those projects were funded again to continue their work. As you can see, really working in all populations who are in need of HIV services and who are in need of, you know, we need to get these interventions into their lives and in a way that's comfortable to them. We have a number, they partner with a number of organizations. Again, I think this request for partnership was really key. And a number of them who have written grants have, you know, been successful in getting other grants. So again, sorry, you can't take questions. We're going really quickly, but you know, we'll have some time at the end for all those questions. So now I'm going to turn it over to Brian. Thank you.
Thanks so much, Nanette. And we're going to stick with this slide set here. Hopefully that is staying up. Yeah, so Nanette introduced the ISCI as the National Coordinating Center, but we also have the benefit of these 8 amazing hubs, and I just was going to share a little bit about some of the activities that the hubs do. So the implementation research hubs, there's 8 currently funded as R24. As you can see, they're geographically dispersed throughout the United States, most within or neighboring to EHE priority jurisdictions and have relationships within EHE priority jurisdictions. In a second, you're going to hear actually from each of the hubs. We're going to do quick flash talks to share a little bit about something unique that each hub does. And I'm just going to share a little bit about the things that all of the hubs do. And so you can see here what we call CHESHIRE, which is the combination of ISCI and the hubs. So for many years, we would say ISCI hub, and we decided to kind of brand the collaboration between ISCI and the hubs to make it a little clearer, which we call CHESHIRE. And some of the activities that the hubs do is they do capacity building and technical assistance with funded projects currently, focused on helping them think through models, frameworks, measuring outcomes, methodological challenges that projects might be facing. They also do training, workshops, webinars, and also for the first phase of EHE, it was really important for us to collect outcomes and progress from the projects to share and understand the benefit of this substantial investment that was made. And so the hubs actually work with each of the projects to help collect outcomes, which they then report to ISCI. We sort of pull that together into a full report of the sort of outcomes that have come out of the funded projects. There's some training opportunities that are sort of across ISCI and the hubs. So ISCI has a program called POISE, which Nanette leads, which is actually designed for folks who are working in practice settings. So clinic managers, prevention folks in health departments, even clinician leads, to really train folks who are doing implementation in implementation research, so that they can be consumers of implementation research and also be partners that are informed about implementation research that can come to the table and collaborate with implementation researchers. And then we have the Visiting Scholars Program, which is really a coaching and mentorship program for folks who want to apply implementation research in academic community partnerships. And so it's a multi-month program. They get assigned to a mentor who does sort of coaching with them, and we have some didactic content. POISE has had 20 participants over 2 years. Visiting Scholars have had 16, and you can see the deadlines are still open for the next round of those programs. So if you're interested in joining, if you're a practitioner who wants to learn more about implementation research, POISE is a fantastic opportunity. If you're a scientist who wants to do community-engaged implementation research, the Visiting Scholars program is great, and you get connected to some of the experts at the hubs to get some mentorship and coaching. For much of the last few years, what we did was work primarily with projects that had already been selected for funding with EHE dollars to give them coaching and to help with coordination of outcomes and data collection. And we're really excited to announce that we're now opening up the opportunity for people who are working on proposals to get access to coaching and to get access to thinking about the outcomes that they should measure in their project. This just went live, I believe, this morning. So if you scan the QR code, you can go to a form to fill out to request support for your pre-award. You're thinking about an implementation research project, and you'd like to get some coaching on theories, models, frameworks, measures, outcomes, things like that. So fill out the form, and ISCI will then match you to a hub who can do a coaching session with you. And as Nanette said, really across these pillars, after the last 8 years of coordinating this activity, we've really developed this model of thinking about the importance of these literature reviews to sort of take stock of what has been learned, what are the gaps, what are the opportunities, the coordination, the importance of shared outcomes across projects. This is a fast-moving, fast-growing area, and if everybody measures the same construct in a different way, we're not really going to be able to learn lessons as efficiently as we want. So the importance of that coordination and common data elements. And then the importance of multi-site research, which we'll hear more about from Geri Schwartz in a minute. So heading into this discussion today, we thought it's clear, from Dr. Donenberg's remarks, from NIH director and leadership that HIV implementation science is poised for additional growth. And so what we wanted to do was take a second to take stock of what is the evidence of the growth that's already occurred, and what is the capacity of the field for further growth. And so we worked with our health sciences librarians at Northwestern to do a review, to do a bibliometric analysis, and it involved a PubMed search. We then used natural language processing to analyze the results to make sure that the work was either happening in the United States or was happening in the United States and in other countries. We then used a machine learning approach to analyze the records that came out to try to make sure that they are implementation science, implementation research. We trained that on 290 records that we knew were implementation research, and then randomly reviewed that against 250 records to confirm that it's implementation research. Of course, anything using machine learning and natural language processing, there's going to be some errors. There's going to be some studies that were excluded or included that shouldn't have been, but we think this is a replicable approach to take stock of the field. And I want to share some of these results with you, which we just actually got last week, so they're really hot off the press. And some of the takeaways, if you look at the slide on the right in particular, this is the annual growth in implementation science publications over time compared to growth in HIV research overall. Again, this is all domestic literature based on the natural language processing. And what we're seeing in the slide on the right is that HIV implementation science is expanding much more rapidly than HIV research overall. And if we look at the 10-year period from 2015 to 2025, implementation science publications grew at over 4% per year. And that's compared to less than 0.1% for HIV research overall, which means that HIV implementation science is growing 61 times faster than HIV research overall during that period. So we're seeing tremendous growth in the published literature around HIV implementation science over this time. The other thing we did is this term co-occurrence density analysis. And this is an approach to sort of visualize the conceptual landscape of a particular area. So this is an analysis of HIV research overall and the HIV implementation research from that systematic review. And you can see in this period from 2015 through 2020, the density shading reflects where terms cluster together more strongly. So these are like dominant areas of activity in the field in a particular time. There are implementation research terms that are present. We see implementation, adoptions, barriers, facilitators, acceptability, for example, but they are scattered across unrelated clusters and don't form a unified conceptual space. That indicates that while implementation science was emerging during this time, it hadn't matured into its own research domain within HIV work during this field. Whereas we see other more established domains that you'd expect to see, like antiviral drug discovery, clinical HIV treatment, et cetera. And what we see then when we fast forward to the current period, 2021 through 2025, we see the emergence of implementation science as a conceptual field within the HIV research literature. This map shows, again, the thematic areas from 2021 to 2025. And there is this very clear cluster of implementation science along with HIV prevention. This includes terms like acceptability, uptake, barriers, facilitators, engagement, and PrEP, which are all core concepts in implementation research that are co-occurring in a cohesive way. I think that the relationship between implementation research and PrEP makes a lot of sense, because when we did the analysis of the portfolio of EHE projects, most EHE projects were focused on PrEP. So there was an infusion of research in HIV implementation research and PrEP. So it makes sense that prevention and implementation research are so closely linked. Now, who funded the support of this giant growth in HIV implementation research? So from the published articles, we extracted the funders, and you can see that implementation science in HIV domestically exists largely because NIH has invested consistently, and this is across multiple institutes and centers. NIH support far exceeds that of other US federal agencies, industry, foundations, international funders. Academic centers and CFARs primarily represent pass-through funding from NIH as well as institutional commitments that have been made to support this work. So I guess this is when I would pause and say thank you, NIH, for being so transformative in the growth of this field. Now I think the question is, are we ready for an infusion of additional resources? What is the capacity of the field? How has the workforce grown over time? And one of the ways we defined that was by looking at authors who had published 3 or more HIV implementation research papers in a given year. So maybe if they'd published 1, they could be still emerging. Maybe they were a co-author or a collaborator. But if you've published 3 HIV implementation research papers in a year as a co-author or an author, this is probably an area that you're actively doing work. And so we defined it using that metric. Obviously, you could choose other cutoffs, but we chose 3+ publications in a year. And this slide shows how HIV implementation science workforce has grown and evolved over this 25-year period. We see 2 important dynamics in the slide. First, we see this continuous influx of new authors each year, which signals strong interest and entry into the field. So the new authors are each year new folks in red who for the first time published 3 or more implementation science articles. The second is we see the continuation of authors who have published 3 or more articles at one time and have continued to do that over time. So this is the robustness of the field over time. And so we see that this suggests there's really an expansion and a maturation of the field. And so, we see very few back in 2000 who were publishing 3 or more articles a year. And now we see over 400 doing domestic HIV implementation science at this point. So the workforce has expanded incredibly, and I think speaks to the capacity for additional work. In terms of a just quick look ahead, what is the importance of HIV implementation science going forward? We know that in the United States, the HIV implementations landscape is changing. Government reform to the way our public health and healthcare sector works, but also interventions changing, like long-acting agents. These are the kinds of questions that implementation research is designed to answer. And so we think as we go forward, it's important to really keep a focus on these partnerships between researchers and service providers. You cannot do implementation science without implementers. The implementers have to be a core part of it from the beginning in terms of designing the questions and the research approaches. And that we think there's opportunities for new models and partnerships between federal funders for service delivery, local health departments, Ryan White clinics, federally qualified health centers, to really do work that's rapid, relevant, and rigorous to quickly transfer knowledge into application. Multi-site research is absolutely essential, so we understand how things are implemented across context, and we'll be hearing more about that from Geri and in a discussion later. And clearly, these metrics show a huge growth in the field of implementation science in terms of the scholarship, the publication, and the workforce, creating capacity for additional work. We want to acknowledge our funders at ISCI. We were originally funded as a supplement to the Third Coast CFAR, and now as an R24. And with that, I want to invite the hub speakers to come up. So Nanette and I shared about ISCI and some of the core activities that are done across all of the hubs. And now we're going to do very quick 5-minute flash talks from each of the hubs to learn a little bit about some of the activities that are unique to each hub, some of the services, programs, tools, and resources that each hub puts out individually. And we will start with Dr. Schwartz.
All right, thank you very much. So I am presenting for the Johns Hopkins IS Hub team on behalf of our leadership and faculty. Steph Baral and Laura Beres are also in the room here, and several other amazing faculty and coordinators. I will say we had to choose one topic to highlight, and it's not easy to do because we do a lot of things. We're doing a lot of work in the community engaged research work. We have an EHE dashboard that is soft launching now. So here's the QR code. Feel free to visit it. It'll have a harder launch in January, and we'll be presenting on it with more data. But these are EHE supplement funded articles that are represented in this dashboard. And we'll be expanding to some other EHE IS HIV work. So what I will be talking about briefly now is our flagship fellowship program, the HIV and Implementation Science Fellowship for Early Stage Investigators. Many of you are probably familiar with this. If not, our philosophy is that the fellowship is didactic. So we have an 8-month training program that includes weekly lectures and online sessions with the faculty that we're presenting, really leading a discussion. It's based on mentorship. So we have so many amazing mentors, many who are leaders from across the Hub network that really are the heart and soul of the fellowship. It's all focused on grant support. So it's focused on learning how to write implementation science HIV grants targeting NIH. And it focuses on networks. And we had a networking session at DNI on Monday, and I had a couple fellows come up and say, it's really the mentorship and the networking that have been so incredibly valuable and continue to bring value, because the network, we bring alumni together. We continue to try and foster those relationships and collaborations. And I will say it is probably my favorite part of my job, the fellowship. We've trained 147 fellows so far. We're in our 7th cohort right now. We currently have 18 fellows. The fellows have come from 58 institutions, and over 74, probably 75 now fellows have received a total of 140 implementation science HIV NIH grants. So that is a real, I think, testament to the success of the program. We have mentors from across the 7 hubs and 13 universities. We don't have a lot of slides, so I didn't show all of their faces, but I will say they are amazing, and they bring so much energy and joy to the program and support without very much compensation to the fellows, sometimes with no compensation. So it has been, we believe, a really successful program, and that is because of all of the many people that are involved. This is just a quick look, the last slide, of the range of some of the funding sources for those fellows. So you can see that they're receiving different types of grants, a lot of R01s, some Ks, and they're receiving funding across agencies. NIMH has been in the lead in terms of support that the fellows have gone on to, grants they've gone on to receive, but quite a few other institutes within NIH as well. So I will leave it there, but just again, a thanks to all of the mentors in this room and who aren't in the room for all of their support of the program over the years.
Thanks so much. My name is Luke Davis, and I'm pleased to be presenting on behalf of the READY Hub. Yale READY Hub stands for Rigorous, Rapid, and Relevant Evidence, Adaptation, and Implementation to End the HIV Epidemic. And on behalf of Debbie Humphreys and my colleagues, Christine Brown, Raul Hernandez-Ramirez, and Nikita Rao, as well as Ellie Zelazny, who's our center coordinator, and an illustrious collection of co-investigators and community members, I'm pleased to tell you a little bit about our hub. We are based at the Yale School of Public Health, and we benefit from partnerships with the Yale Center for Interdisciplinary Research on AIDS, which is an NIMH P30 funded AIDS research center with a strong focus on HIV implementation science in the New England region, as well as the Yale Center for Methods and Implementation and Prevention Sciences, or CMIPS, which is our implementation science center, which has a strong focus on developing methods, both quantitative methods and qualitative methods. Over the last few years, a growing amount of evidence in the field of implementation science has demonstrated that the community-engaged approaches are much more powerful in implementing evidence-based practices than practices that are coming from investigators alone, for example. And that's going to be the focus of my talk today. So in order to conduct this research, we started by reviewing the literature to try to understand what types of research are being done in the field of community-engaged research. We did a systematic review and identified over 370 articles that mentioned community engagement in some way. And the goal of this was really to understand the depth of engagement. When we think about community engagement, that's a broad term that can mean many different things. And if you look at the graph on the right side of the slide, you can see that we've described these different stages of implementation, from at the left, kind of the least amount of engagement with the community. And at the right side of the slide, you can see the most amount of engagement with the community. And the proportion of studies is represented. And first of all, a large proportion of these studies, over a third of them, even though they mention community engagement as a major focus of their study, didn't give them methods to describe how they used community-engaged research. And then among the other studies, only about half of them used what we'd call highly engaged approaches, such as community-based participatory research or community-led research. And there really wasn't much of a difference either before the EHE or after the EHE. So in thinking about this, we wanted to figure out how could we work with the community and what parts of the community that we want to engage. And so we took advantage of a framework called the 7 Ps framework developed by Concannon and colleagues, which layers on the social ecological model some thoughts about who those stakeholders are. And we know that with traditional efficacy or effectiveness research, there's a large amount of engagement with the people at the outermost levels, the policymakers, the purchasers and the payers, and the folks who are making the drugs, devices, and tests that are very important for advancing HIV innovations. And principal investigators kind of sit at the middle, but as we think about implementation research, there's really a need to look inward and approach those people at the front lines, such as providers and implementing partners, as well as, of course, participants and the public, who really have the opportunity to take these things forward. And so we're developing 3 types of resources, technical resources, in order to do this. The first is a community-based participatory research training for researchers. We're doing that in partnership with community partners. It's a 6-hour approach to kind of teach implementation researchers how to approach the community, what principles are important, and most importantly, what are some practical ways of building strong and lasting partnerships. Second, we're going to be convening what we call a community of practice for implementing partners. And the goal there is really to take advantage of the tacit knowledge that implementing partners have from working in communities over the years and surface some of these strategies that are very effective, because we know that partners can learn from each other if we create the environment for them to do so. And then finally, a very important part of this is to not just learn, but also to disseminate, to spread across the country to these 57 EHE regions. And in that regard, we're testing and refining community-facing dissemination templates, such as what you see there on the right, which incorporate infographics and communicate in ways that are easily understood what these efforts are. Overall goal here is to strengthen partnerships and build better relationships for implementation science research. Thank you.
Good morning, everyone. My name is Borshika Rabin, and I am presenting on behalf of our San Diego Implementation Science Hub. Our 2 other MPIs are in the audience, Dr. Nicole Stadnik and Dr. Laramie Smith. And I am presenting on behalf of our team that has really come together over the past several years. Most of our investigators that you see here are internationally known implementation science methodologists or HIV and implementation science researchers. In this current round, we added some additional advanced methodological expertise in large language models, AI, machine learning, and then also cost effectiveness analysis and more advanced modeling, which I think will really make our team stronger. We are also including a member of our grants management team as a co-investigator to help us train our community partners in how to implement grants. So that was an important addition. Our team is really functional because we have an incredible staff. 2 of them are listed there, and they are actually trained as mid-level implementation specialists, which really made us more able to reach more individuals and more ways. So that's exciting to us. And of course, we are really relying on a steady stream of amazing interns at different levels, which also allows us to do some mentoring and capacity building on the educational side. Again, new to this round of our hub, we are including very strong established partnerships with community partners. So the individuals or the groups that you see listed on the left side of the slide are partners who we have worked with in the past, but in this round we actually established contractual relationship with them, and they are co-creating with us, which is, you will see why it is important. And then in terms of institutional partnerships, we are currently housed within the School of Public Health, which is a new home for us. But it's a very exciting home that expands our reach. We are continuing our very strong partnership with the San Diego CFAR, and then we have an ACTRI, which is the CTSA, with an implementation science center, but also community engagement units and other resources that we benefit from. So as all of us, we are limiting our presentation to 1 to 2 resources. So I am going to sneak in 2, but it's a common theme. So the common theme that I would like to highlight is that we are trying to de-jargonize and make implementation science more accessible to all. And so on the right side of the slide, you can see the Dissemination and Implementation Models web tool, which was actually developed with NIH funding 12 years ago, and we have maintained it. But with the hub support, we were able to develop an HIV-specific section, which is providing guidance, hopefully easily accessible guidance, to researchers who are not necessarily implementation scientists, because many of our clients are not going to become implementation scientists, but they want to be savvy about using, selecting, operationalizing tools. And so the HIV news section was actually featured at the DNI conference. We did live demo, and we have a publication led by Nicole and others in the works to put that out. We also have, as part of that, about 20 case studies. So case examples of how you can use implementation science theories, models, and frameworks in an optimal way in HIV research. And then finally, for that side, we are moving in the direction of creating an actual live repository of assessment instruments for implementation science. That's the brown button, the assess. And as part of that, the hub is going to work on expanding that repository, which currently have about 75 instruments, for more HIV-specific IS instruments. So if you want to contribute to that, please use that QR code and send us the instruments. Going on the other side, as I said, we want to make implementation science accessible to all. We established an implementer learning core, and this is where our community partners are going to co-create learning materials for community partners about implementation science. So we hope that they can become citizen scientists with us, work on implementation science in a way that it's meaningful to them. Thank you so much.
So hi, everyone. My name is Carolyn Odette, and I am sort of representing the Southeast HIV Implementation Hub. So our project, we are the only group that took the original advice to partner with another institution. So everyone else was like, no, thank you. But Jessica and I like each other quite a lot. And because we are in the Southeast region, we decided that partnering together could actually provide some more additional support for people who are working in the Southeast region, which, as you all know, has one of the highest incidence and prevalence rates in the country. We have a lot of investigators who are working with us, Patrick Sullivan and April Pettit, who are at Vanderbilt and at Emory. We also are working with Washington University in St. Louis for additional training support for those who we are supporting. And we have a number of great partners at Emory and at Vanderbilt. So what's our cool thing? So I think we spend a lot of years sort of supporting people on learning implementation science methods and writing grants, and sort of people were very successful in that area. And then what we realized is they would finish the grant and they would be like, yes, so what's next? We were like, you have to disseminate this, you have to make this sustainable. So our one thing that we wanted to highlight this year is focusing on every grantee who has a successful project or sort of wants to keep things going. They will have sort of an opportunity to spend 3 different sessions with a dissemination expert. They will learn how to communicate their science to different levels, whether that is sort of the person who's in charge of the health system, whether it's to healthcare providers, whether it's to patients, to community members. They will learn how to do that. They will also do a lot of transition planning, so creating documents that will then sort of be very easy to read, whether it's a video maybe, so something that's easy for people to watch, basically practical support in order to make sure that their successful implementation continues, so that projects can keep working and sort of can keep providing that additional support to people. We will also be providing cost effectiveness training so that people can make sure that they can provide that information to providers and to health systems as well, because this thing might work really well, but if it costs like $25 million, nobody cares. So we want to make sure that not only can this be sustainable, but it can be cost effective and people can keep their work going for longer periods of time. So thank you very much.
Good morning. My name is Serena Rodriguez. I am representing the Texas IS Hub. So this is us. I'm one of the co-directors of the Texas IS Hub, along with Dr. Bijal Bella Subramanian and Chris Markham. Meryl is here, our fabulous coordinator. We have a whole team of investigators from across the state of Texas. We partner very closely with Baylor College of Medicine. And if you know anything about Texas, you just know it's huge, right? So one of the unique things about our university, the UT Health Houston School of Public Health, is that we have campuses all across Texas. I'm at our Dallas campus. We have investigators in Houston. We also have campuses in Austin, San Antonio, El Paso, and Brownsville. And so we really have this statewide presence where we're able to work with communities across the state and address needs. So our cool things, I like how you said that, our cool thing. We have a lot of expertise in the processes called implementation mapping and IAM-ADAPT. So when we're developing, when we have EBIs, things that we know work and we need to get them implemented effectively, to develop implementation strategies, we use a process called implementation mapping. This is a very systematic process that helps unpack the black box of what we're doing, why we think these strategies are going to work to ensure effective implementation and adoption. We also have a process, and this QR code can take you to the paper. We have lots of examples of how to use IAM implementation mapping. We also have a process called IAM-ADAPT, which is a systematic process for adapting evidence-based interventions, so practices, policies, and programs. And that is actually a web tool that the QR code will take you right to. I also included some of our sort of select topic areas of expertise that we have on our team. So we've partnered with grantees who had pharmacy-based interventions, a lot of community engaged research, which you've heard a lot about. We have significant expertise in substance use prevention, treatment, and recovery support services, so a network of recovery homes across the state of Texas, EBI adaptations, implementation strategy development, as I said. And then also we have statisticians on our team with expertise in hybrid trial designs. So if any of that sounds like something you're interested in, want additional support or training in to those online, feel free to reach out to our hub, and yeah, I will hand it over.
Okay, I'm the other Southeastern hub, I guess. I'm from the University of Alabama at Birmingham, and have a stellar leadership team here. Would love to introduce. I am MPI along with Dr. Renee Heffron at UAB, and just thrilled to have Dr. Ann Numcomb, our program director at our hub. And we have such a wonderful group. Associate directors are Doctors Larry Harold and Mike Magavero, who were MPIs this past set of years during the supplement phase. And we have a lot of various experts that really focus on a variety of aspects. On the top, you can see our community engagement experts from the field. So we have partnered with our AIDS service organizations and have Larry Cowan and Jean Hernandez as part of our team, along with Hassan Hawthorne, who provides a lot of community engagement expertise. And as you can see, we have a number of both clinic as well as community expertise that are part of our hub. Being rooted in the US, we are thrilled to be able to bring leadership from the Alabama AIDS service organizations and real world implementation expertise. We contribute largely, and as you can see at the bottom, Dr. Reena Patel and Tina Kempen-Reuter, who really bring social determinants of health, as well as being able to look at health policy. And I think that that's really been a nice addition to our hub this go round. And focus a lot, those in the middle, Dr. Adia Rana and Bertha Hidalgo, and Allison Varley and Julie Schnex-Nader, I always struggle with the name, help focus on us with clinic as well as community-based organizations, and being able to look at the academic public health departments in our collaborations and doing dissemination science, which Dr. Bertha Hidalgo focuses a lot on. Okay, so our cool thing is pre-award. So we are really focused on the pre-award phase, something unique I think that we are really digging into this time. and trying to look at pre-award support for investigators conceiving as well as preparing their grant proposals, and then for pre-award networking for investigators to leverage partnerships because, as I'll explain, we have a lot of wonderful connections in that area. So our pre-award support, technical advising, coaching, and conversation hours for people conceiving and preparing their implementation science grant proposals. We feel that this is novel this time as we have really focused largely to this extent on the post-award phase. And so what we are doing is looking at how we can help with that pre-award networking capacity for investigators wishing to leverage some of our national cohort and databases such as the CNICS, CFAR Network, and Integrated Clinical Systems. So for the bulleted points here, first, we provide tailored technical advising on implementation science methods and study design, implementation strategies, and use of theories, models, and frameworks, including how structural and social conditions shape implementation. For example, with our hub's expertise in social determinants of health and implementation science, we support investigators to integrate measurement of social determinants of health and leverage an investigator's relationships with stakeholders to formulate strategies that address social determinants of health and sort of a go or no go. And then second, we offer these conversation hours, which we think are really fun ways of sort of just drop in opportunities for in the moment topic specific questions that they may have, and as a way to really sort of do this rapid, low barrier entry point for our pre-award. Third, we provide our coaching that complements technical advising, so it's more on coaching as the investigator versus the project. And fourth, our pre-award services include support for these partnership development and establishing and building on that is our advising investigators on how to work effectively with our major HIV research networks. And then finally, we support implementation science, again, through the clinical and community settings. So I'll leave it at that as I'm at time. Scan our QR codes. I think all of us have some QR codes to sign up for our listserv and get a pre-award consultation going. Thank you.
Hi, everyone. Thank you so much for this opportunity. I'm Allison Hamilton. I lead the UCLA Rapid, Rigorous, and Relevant, or 3R, Implementation Science Hub. And we are also so fortunate to have an amazing team of implementation scientists, leaders in the field, who you can see here. And I think mostly you're quite familiar with their work. So we've been working together for several years and are thrilled to have an opportunity to have 5 more years together. Our focus in the next 5 years, our new thing, is going to be working at the intersection of implementation science and improvement science. We feel that one of the ways that we can make implementation science more accessible is through that pathway of improvement science and using quality improvement as an implementation strategy. So we've brought in some additional experts in system science and quality improvement. And I do a lot of work in the area of evidence-based quality improvement in particular. So we have an existing training that we're going to be adapting through our hub that integrates equity and tailors to HIV service organizations, and then use that approach to work with community partners on improvement science capacity building. So we feel like, sometimes the introduction of implementation science into community-based settings may not be quite so familiar or accessible, but quality improvement has a bit more resonance and familiarity, and so we really want to capitalize on that, offer evidence-based quality improvement training, and then offer mentorship to community-based practitioners, healthcare providers, partners, et cetera, who become familiar with evidence-based quality improvement and then may want to use it as an approach in their healthcare systems. So we're really excited about this. We'll be, building out additional resources at that interface of implementation science and improvement science, and really look forward to sharing this with our HIV service community. So thank you so much.
All right, good morning, everybody. My name is Kenneth Scher. I am here on behalf of the University of Washington RAISE Implementation Science Hub. And I want to just say that we didn't plan to have, when we sat down and wrote these proposals, to have totally different foci. It's pretty amazing to see how everybody is doing something unique and really collaborative. So like all the other hubs, we have an amazing team. I lead the hub in conjunction with Emma Murphy, who's here with us today. And then we have a great set of consultation faculty led by Ariana Means, who leads consultation processes. Manisha Sharma brings in health economics and disease modeling expertise. Sarah Gimbel, expertise on implementation science frameworks, outcomes, and mixed methods design. And Anjali Wagner in implementation strategy, optimization, adaptation. And then Tim Menza also provides consultation services and is participating in the HIV and IS Scholars program. Christine Kostrapor is leading our RAISE Hub Health Department training and resource area together with Roxanne Karani, and I'll talk about what they're doing in just a minute. And then Matt Golden, who's the director of Seattle, Public Health Seattle King County's HIV, STI, and Hepatitis C program, in conjunction with Julie Dombrowski, are both leading our low barrier care and data to care learning collaboratives. And then Krupa Mehta from NASDAD, the National Alliance of State and Territorial AIDS Directors, is part of our team and is helping to create our learning platform for health departments. So what is RAISE doing that's distinct from other hubs? Really focusing on health departments, and focusing on health departments because they're receiving such a large amount of funding for HIV control, and they have that role to coordinate, to evaluate, to adopt, to sustain, and to scale effective strategies as part of their mandate. So we really want to focus our work on integrating implementation science into health department DNA. And we're doing that through a couple of different ways. First is in conjunction with NASDAD. We have a seminar series that focuses on health department personnel and how implementation science methods can be practically incorporated into their work. Our personnel provide consultations for health department staff and site visits upon request. And then we started 2 years ago, so we're entering our third round, an annual evaluating the EHE implementation workshop for health department staff, and focusing on HIV evaluators within health departments and their local and state health departments. And so we provide them with a 1-week in-person training on implementation science methods, and then develop during that week an evaluation plan incorporating HIV implementation science methodology. We hope that and expect that this provides a platform for peer-to-peer learning and that dedicated time they need to develop a robust mixed methods evaluation plan to really surface what are the strategies that they're implementing that are most effective. And then we continue to provide ongoing support to the 30 EEI graduates to date. And then we'll be having our next evaluation training in April 26. And then we decided, beginning this next year, to have a second advanced EEI workshop for participants who want to continue learning about implementation science. So this is going to be a biannual workshop where they're going to delve deeper into IS methods, and hopefully, or the intent is to develop implementation science champions within local and state health departments. So say the geographic representation of this activity has been quite broad. We've had, I'd say, an oversampling of participants from the Southeast, but they really are coming from EHE jurisdictions nationwide. And then the second component, which is new, is the development of 2 18-month learning collaboratives focusing on implementing 2 strategies to improve HIV treatment. One is low barrier care, and the second is data to care. So we will be launching this in February of 2026. We're going to have 6 teams that include health department personnel and local HIV care providing organizations. These are all Ryan White Care funded clinics. And the intent here is that teams will, by the end of the 18 months, have increased their capacity to design, implement, monitor, and evaluate low barrier care strategies and data to care strategies for HIV treatment. Thank you so much.
All right, please join me in thanking everyone again for presenting on such unique opportunities at each of the hubs. As we wait for the hub leaders to transition out and for Debbie Humphreys to come up, I just wanted to add that, despite all of the really cool, unique features that we just heard about, the hub spent yesterday strategic planning about all of the collaborative stuff that we were doing together. So there's it's a really wonderful collaborative group that supports each other and allows each other to shine. So I'm going to turn it over to Debbie Humphreys, who is going to talk about the evaluation of our activities so far, and then the presentations will transition directly into Cherie Schwartz, who will talk about the multi-site stuff.
I really appreciate the opportunity to be here today and to get to walk you through the evaluation that we've done in trying to understand the impact, because we don't always pause. These kinds of capacity building activities are really hard to look at and to figure out what happened because of them. And so a year and a half ago, the hubs in ISCI said, we need to figure out what the impact was. And so we actually pulled together a working group to look at that evaluation and to design an evaluation and then to carry it out in a very focused time period. We had all kinds of dreams about all the questions we would love to address in an unlimited period of time. That was not our situation. So we chose to focus on 3 questions. 1, how did the network impact the knowledge, skills, and practices of scientists engaged in the EHE and their research teams? 2nd, how did the network impact collaborations, relationships? And 3rd, how did it impact productivity? We had, in the best of all possible worlds, we would have been able to look at the next level, what happened at the community level, but we had a very limited, we were all reaching the end of the grants and just needed to do a baseline. And so we basically said, let's start, figure out the methods, figure out how to do this, and then we can do more if and when we get the next round of funding. So with these 3 questions, we put together 3 working groups that actually included people from all of the hubs, and a qualitative analysis working group, a social network analysis working group, and then the data integration working group, or DIG. I'm going to start with that first question, impact on skills, knowledge, and practices, and with the work that the DIG team did. So the DIG team, data integration, looked at existing data, and they pulled together data that ISCI had collected on what happened with the hubs, what happened with the projects. A survey went out to every EHE project and said, when they first started, what's your level of IS competency? How much do you know about implementation science? How confident are you? And then that went back at the end to ask, how are you feeling about those competencies at the end of your supplement? And what we looked at was the change. We also brought in the hub records. So we went back to all the hubs and said, okay, so for each of the funded projects assigned to you, how many times did you meet with them? So that we could look at the dose of the hubs that they received. These are the 10 competencies that we used. They came out of a lit review and developing implementation science competencies for dissemination and implementation. And then we used the top 3 to calculate a consolidated measure. We couldn't do the knowledge based on all 10. We needed to just have a consolidated measure that we could use. So then, looking at change in those 10, the key pieces here, the blue is advanced, the orange is beginner, there's more blue, the blue goes up, the orange goes down. And then on the far right, you see actually the increases in the advanced levels of knowledge. And so across those competencies, except for that one, differentiating between implementation science and related fields, every one of the other competencies went up. In addition, when we look at people that just have a beginner or intermediate level, so the ones that have capacity to grow, when we look at the changes there, we see that, interestingly, the greatest increases in knowledge were in the partnerships. We're in how to identify and develop sustainable partnerships. And in some ways, this speaks back to the funding opportunities that really emphasized that. Then, in also noting when participatory research is appropriate and how you go about doing it and how you understand the value and importance of each of the stakeholders. Going back to that data from the hubs on the number of meetings, I think the key thing here to note is that the median number of meetings across that bottom, that for the beginners, it was 3. For the intermediate, people that were intermediate level of knowledge at the beginning, it was 4. And for advanced, it was 2. You know, we could unpack that forever. I would hypothesize that sometimes you have to know what you don't know. And when you're at the very beginning, you may not even know what questions to ask. And so the challenge of bringing in people at the beginning level and helping them to understand how they can use the hubs was a challenge that I think we all experienced. So in terms of skills, consistent increases in advanced implementation science knowledge, decreases in beginner, and the largest gains were in communicating terminology, understanding the context, applying frameworks, and then describing organizational relationships. We also reached out to interview these supplements to get their perspective, to get a deeper understanding of what they experienced. And so initially, you know, we imagined that we could ask supplements that hubs said had limited engagement and supplements that hubs had said had large engagement, because we would love to understand what led to both of those. That really didn't work. We very quickly had to pivot. You'll also notice that our initial request for interviews was in December 2024, not a really optimum time for this field. People were not that excited. And so we ended up expanding the outreach to all of the grantees, and by May, we were able to get 14 interviews. We asked about prior implementation science experience, their role in the projects, how they engaged with the hubs, what they thought of the hubs' scientists' expertise, and what the value added was from the hubs, additional resources that they used, ways to improve hub engagement and support. And then we also had them do a REDCap survey where we could get a little bit of information about who they were. And it included closed-ended and Likert items. And that's what I'll show those in just a moment. So the thematic analysis really focused on the questions, the research questions that we had identified, knowledge, impacts, and how they experienced the engagement with the hub. From that closed-ended survey, what we know is that half of the participants had been in their role for 3 to 5 years. Half of them reported intermediate expertise. And their perceptions, satisfaction, 79% said they were very satisfied or extremely satisfied, and thought that there was quite a bit of value. And, you know, we can't say these are representative. This is who we talked to. In terms of the impacts on knowledge, it really fostered confidence. Engagement with the hubs fostered confidence in using methods and terminology. I hadn't heard about the rapid qualitative analysis, and they helped us sort of walk me through it. And so there was a companionship and a walking through that helped someone become comfortable with new methods. There have been times like when I'm working on a new proposal, and I just reached out to the hub, and they were happy to talk to me, to schedule like kind of impromptu meetings. So they really appreciated that kind of engagement that let them strengthen the work they were doing. It also helped researchers apply implementation science frameworks more effectively. What they've been helpful in doing is really specifically in the REAIM outcomes framework, which is quite complex And they've really helped swift thinking through the specifics of how we're going to collect the data that will assess each of the different REAIM components. It really helped understand the concepts, develop logic models, got a step-by-step guidance. So really speaking to the intensive nature of what the hubs were able to do and how they were able to support the projects. Practices, I really feel more comfortable with some of the frameworks of implementation science and how to create a study design based on implementation science because of engagements with the hub. Relationships, and we'll come back to that in just a moment. My experience working with both hubs has been great and super useful and also fun, right? Like it was useful and the conversations have been fun and built relationships, and that makes all of this work, I don't know, working in the field, it makes it better. And so that ability to reach out and support other researchers in a way that leaves them feeling happy is a gift. And I think a lot of the hubs have worked hard to be able to provide that kind of support. A couple of other themes. Engagement was shaped by institutional constraints, IRB applications, you know, the deadlines and when it went in and when it was approved, and maybe they didn't even get moving forward until far into the timeline of their grant proposal. Helpful forms of engagement, tailored consultations, feedback on grants. And just really calling out that sometimes it was the projects that needed to take the initiative to engage, that the hubs were there, but they knew, you know, sometimes it's like myself, making the time to participate. Impact on knowledge and practices. Hub support strengthened the application of implementation science frameworks and methods, study planning, confidence, relationships, and it was really shaped by the engagement was shaped by constraints and the project stages. Going more deeply into those relationships. So key piece, this really is a network intervention, these connections, and acknowledging that, we decided to do a social network analysis. And the sample size is 265 people. That's all of the people that engaged, that received either an EHE supplement or were affiliated with one of the hubs, or both. We sent a long email out to all of them, 30 minutes plus, and that literally gave them a list of those 265 people and said, how many of these do you know? And if you checked anybody, then you got asked more questions about them. So we really appreciate all of the 140 that responded was a gift. And this was across the years, the different roles, and so on. What we want to note is that the participants reported about 400 more relationships after participating in the EHE supplement and the Cheshire network, which is an increase of about 30%. 77% of the post relationships were EHE related, and 47% were new, and 34% were expanded from before the projects. Calling out specifically here some of the network metrics, I really want to note the EHE related ties. That 77, you know, any scientific relationship that was EHE related was 77% of all of the relationships they had. 88% of the mentoring relationships were EHE related, 82% of those that were proposing or conducting research together, and then 81% of the dissemination relationships were EHE related. It's a really high amount and really speaks to some of the networking of the hubs. We also had an open-ended question at the end of that 30-minute survey, and 30% of the people that took the survey completed that open-ended question. And we asked any additional connections or collaborations, any stories, specific experiences. it's a really rich set of data. And I'm just calling out two. One person that said, I got to work at a drop-in community center with people that are homeless. And the supplement, I feel like these opportunities let us do research that is ecologically valid and respectful of the communities we want to serve. Second one really spoke to the career advancement opportunities that happened. The supplement grant led me meeting new people. Specifically at this CERT conference, I co-authored a paper with another doctor, and the knowledge gained led to 2 new IS research proposals, one of which was funded and one of which is under review. Lots of academic opportunities that the participants reported. Key pieces from the relationships and networks, 30% increase, average of 2 new professional relationships. One of the other key pieces is that the structure of the network is much more connected. At the end of this, people know more people, and there's fewer pinch points in the relationships. Perceived impacts, expanded IS and HIV collaboration networks, peer learning, and new community partnerships. Back to all those partnerships. Final piece I want to share is on productivity. We want to, these are those good academic metrics that we need. We went to NIH Reporter, PubMed, and to the ISCI reports. We looked at grant awards and peer-reviewed publications. And then we wanted to link productivity to CHESHIRE engagement, descriptive and trend analysis to be able to look at output growth over time. So we were looking at the impact of CHESHIRE, interactions with the hubs on productivity, grants and publications. We measured the interactions with the hub in 2 ways. One was the satisfaction. The other was the number of one-on-one meetings. We measured productivity by the number of federal grants awarded and the number of first author and last author C4 and ARC affiliated publications. Satisfaction, first of all, 84% reported being very satisfied or satisfied with working with the hub. And there's a higher number of the grants and first author publications among projects who were very satisfied or satisfied. There's also a higher level of publications among projects that were satisfied or very satisfied. And that trend holds when we stratify, when we pull it apart by baseline implementation science knowledge and by the project fiscal year, but I'm not showing all of those additional figures. In terms of number of meetings, so now we're going back to that other side of hub engagement, which is the number of meetings they had. The data there was a little less clear. Overall, as the number of meetings increases, the percentage of projects with more than 1 publication goes up, and it holds in beginner and intermediate, not advanced levels of knowledge. And I really just want to pull that piece together with a higher number of grants and first last author publications among the projects who were very satisfied or satisfied. And as the number of meetings with the hub increases, the percentage of projects with more than 1 first and last author publication increases. The hub engagement and the grants were a little bit more difficult to tease apart, and there's no 30-second soundbite there. I also want to call out one of the other things that we were able to pull together was that together we offered 947 one-on-one coaching consultations with the projects. Over 218 distinct learning opportunities, webinars, workshops, lectures, and seminars. 2 or more hubs co-sponsored 55 seminars, and continuous activity from 2019 to now, participation from across the US and internationally, and participation from a range of stakeholders. Key impacts, more IS knowledge. That it's clear that participants know more when they finished. There's more academic and community partnerships. There's greater productivity. more scientists with advanced knowledge, less with beginner, targeted hub support contributed to those improvements. Relationships, that 30% increase in collaborations, and it's related to the EHE engagement, more robust and distributed connectivity, and those new and stronger community partnerships. And then the productivity, more grants and publications among satisfied and very satisfied projects. So I want to acknowledge that this is work that was done by a huge team. The DIG team, led by Christine Kosrapor from UW, Jay Lee from UCLA, and all of the other people on that team. The qualitative working group, led by Carolyn Odette at Vanderbilt, and also filled with an amazing group of people. Social network analysis, led by Alex Morshed at Emory, and the rest of us on that team. Funding. Questions we really want to ask the next time: what's the impact outside of the EHE scientists? There you go.
All right. Hi again. Sheree Schwartz. I'll be talking about some of the multi-site research that our hubs had the opportunity to participate in. So there have been so many people involved in this initiative. I can't name them all, but I will just say thank you to them, and also note a note of thanks to NIH for supporting this multi-site research, allowing us to use some of our initial hub funds to pilot this concept. So I will be brief today, but I'm going to talk a little bit very briefly about why multi-site research, give you some findings, an overview to Niche 001 and those findings, and just reflect very briefly about some of the lessons from that work. So why do we think multi-site research is important? So just as clinical trials often require many participants or patients in order to establish the efficacy of a drug, when we're thinking about implementation, we require lots of different organizations, healthcare delivery sites, providers to be able to test our implementation strategies. And internal validity of studies is important. I don't think there's any implementation scientists that would argue against that, but really balancing external validity and thinking about the richness that contextual variation brings is absolutely essential and is an important component to multi-site research. While tailoring is recognized as key for implementation, constant recreation of the wheel is inefficient, and it fails to recognize that there are some common lessons that can be learned across sites and some core components that can be applied broadly and allow the tailoring to be a little bit more limited. And these were really some of our goals in thinking about what could we do and plan for in the future with multi-site research. So if you've seen one Ryan White clinic, you've seen one Ryan White clinic, right? So we believe that multi-site research is very key because it's necessary to test the effects of strategies and match the strategy to the context. And what you see here on the figure on the left is recognition that it's really not about how many people are within a clinic being served by the clinic or how many providers. It's really about trying to get a number of those facilities, of those clinics in order to improve precision when you're talking about cluster randomized trials. And similarly, by thinking about an array of sites, it allows you to have outer setting contextual variation and inner setting contextual variation, which is critical if you're really trying to promote external validity in your research. So I'll be talking a little bit about Niche 001. What is NICHE? We're not going to spend a lot of time talking about that, but it's the Network for HIV Implementation Science. It really emerged from the CHESHIRE network, from the hubs and ISCI. We each put a little bit of money aside in a round of hub awards to do this work together. I would say probably a lot of it was pro bono, each of the hubs would say. But we've had a very good time working collaboratively on this project together. So we started out putting in a bunch of different concepts, taking them to the Community Advisory Council and having them sort of guide us in terms of which one they wanted us to push forward. We developed shared protocols and tools, went through an interesting and challenging IRB process and some lessons learned, and conducted the work and really did a very thorough job, I'll say, disseminating to each of the health departments from the jurisdictions that we were working in. And really trying to ensure that the sites that were engaged got the results reported back to them. So we've had 3 multi-site projects as part of NICHE. I was the protocol chair. I had the honor of being the protocol chair of 001, and those are the results that we'll be focusing on today, but it isn't the only work that's been done through the network. So 001 focused on identifying optimal rapid start implementation strategies, rapid start for both HIV treatment, but also for prevention, so both ART and PrEP. We had the sites across the hub network and site chairs for each of those sites, which are listed here. And I will just mention we had sub-teams led by the site engagement team by Nanette Benbow, the qual team led by Laura Beres, and the quant team led by Sungjae Lee, Donna Spiegelman, and Debbie Humphreys. And they really put so much time and effort into making this study a success. And so I really want to just call them out for all of the work that they've done. So the NICHE network map initially looked like this, and this is what it looked like when we were entering into the multi-site NICHE 001. So you can see that there's quite a bit of geographic diversity represented across our hub network that allowed us to really have an expansive reach in terms of the work. And that has grown a little bit over time with the additional hubs that have been added. I will just note that site selection has been a really critical part of how we've been thinking about this work. You know, we've defined sites as the geographic jurisdictions, but within those sites, you know, there are multiple clinics, CBOs, different partnerships, and we've really relied on the hub network and those local relationships and relationships with health departments and, you know, local CBOs, NGOs to really try and build out the work on the ground and really think about diverse sites that don't just look like stellar academic universities, but look like the sorts of places that people might be accessing HIV care in the country. So what kind of data collection do we do? This wasn't a trial. This was really a proof of concept work, trying to just understand the lay of the land in terms of the implementation across these jurisdictions. We did key informant interviews with health departments. We did surveys. We created a list of all of the Ryan White clinics across those jurisdictions and sent out surveys to the administrators of those clinics. We did focus group discussions with providers from those Ryan White clinics. And we did a few in-depth interviews with patients or clients from those Ryan White clinics because we also wanted to make sure that the patient voices weren't lost in the process. In terms of reach, we were able to reach 40 clinical organizations, which represented 57 clinics. And those 57 clinics served for HIV prevention purposes more than 29,000 people and more than prevention clients and more than 49,000 people living with HIV. So you can see that when you invest in this kind of work, you can actually have a large impact in terms of the number of potential patients that are represented. Not shown here, but what we do know is that the racial and sex representation, the types of clinics, FQHCs, you know, academic universities, CBOs, they were very diverse across these jurisdictions. And so we really were able to get a broad representation. And one of the things that we really had to start tackling from the beginning is, does everyone even have the same definition of rapid start for treatment, for PrEP? And what we quickly learned talking to health departments and reviewing EHE local plans is that no, they didn't have the same way of thinking about Rapid Start. And so that was sort of our starting point, was really working to try and understand and define this. So both for Rapid Start for ART and for PrEP, most commonly with PrEP, there were just no definitions for what rapid PrEP initiation would be. So we looked with our surveys, we looked at what was the adoption of Rapid Start. So you can see that across the jurisdictions, which again are representative of multiple clinics, that many places had adopted Rapid Start for ART, for treatment. Much fewer had adopted Rapid PrEP. And in terms of status neutral, almost none had adopted rapid status neutral, but about 2/3 of the clinics had some form of status neutral that they had adopted. We were really interested in thinking about the heterogeneity of both implementation, but also implementation determinants, so the barriers and the facilitators across jurisdictions. And you can see that there are some commonalities. So financing and insurance delays were seen across the jurisdictions, right? That wasn't specific to just one or two jurisdictions. That was really a key challenge. And in some jurisdictions, we saw that state and county level mandates and policies, funding policies really helped to facilitate implementation, but that didn't exist in other locations. And that there were different strategies in terms of implementation strategies that jurisdictions were using to overcome some of the barriers and implement. So, one of the key things that we felt that we learned from this is that sufficient sample of different contexts is important to really understand generalizability and transportability. That, having multiple states, both Medicaid expansion and non-expansion states, jurisdictions represented, was important for us to really understand what strategies might be necessary going forward. I'm not going to get into the details of this, but this is a mapping of status neutral implementation that our qual team created, work led by Tongying Zhao and Greg Rosen. It's currently under review, but they worked with through focus group discussions with healthcare providers across the Ryan White clinics and across jurisdictions to really understand what status neutral implementation of HIV treatment and prevention could look like within clinics or did look like. And they were really able to define some key difference makers in terms of when implementation existed and didn't exist. And again, these difference makers became more obvious because we had multiple sites represented. So timing of insurance review, for example, was something that really drove whether or not sites were able to implement status neutral versus not. Where did they put that insurance review into the process of seeing clients? The magnitude of workflow integration. So how many times do people have to be passed on to different providers versus having providers that could offer multiple services themselves? Implementation partnership. Did they have HIV testing available on site, or did they have to rely on CBOs to then refer in for testing? And task shifting within the workforce. So there were multiple different difference makers that could be implementation strategy targets for a future trial if you were trying to advance status neutral implementation. This is work that was presented at DNI this week from Laura Beres in a poster providing some of the client insights, both on rapid ART, which is not shown here, and on rapid PrEP. So some of the challenges that clients identified in terms of accessing PrEP rapidly, competing life demands, stigma, but some of the factors that, helped facilitate rapid initiation, awareness and motivation, and then some of the strategies that were identified that could help them get onto PrEP faster, transportation subsidies, connection to other services such as housing, convenient and flexible hours, online appointment scheduling, and supportive, friendly PrEP experienced providers. So that's really just a snapshot of what we learned. We've done a lot of work and wanted to keep it brief, but we've been reflecting a lot about what we were able to do with this study and how that relates to where we could go with multi-site research. So, there really is a power in numbers. And I think just like going back to that slide on reach, with 57 clinics, it represents almost 70,000 individuals that they serve. right? So there's a real power in being able to do work that is so broadly representative of the population. And if we're thinking about this next stage of how we take these evidence-based interventions that we've, as a community, as scientific workforce, have put so much effort into developing, how do we actually get those to people and get them to those who need them the most? We need to be thinking about implementation strategies, and those need to be tested across multiple sites. And this idea that just having one clinic or two clinics that you're working with that are academic centers of excellence isn't really going to facilitate that. And so we really do believe that these approaches can be powerful in terms of their reach and their ability to test things and understand what's generalizable, what's going to work across multiple different types of states and jurisdictions, and what are we going to have to spend a little bit more time tailoring. And so that type of work takes broad representation. We've been fortunate to have so much expertise within the niche network, within the CHESHIRE network, to pull together across implementation science disciplines. And that has really created both a broad geographic, but a broad expertise base to be able to think about these ideas. Secondly, and lastly, just talking a little bit about context versus generalizability. And I think just again, this idea that, I think we all realize that context plays a critical role in implementation. We know that it, often is the determinant, is the key element in terms of identifying what is going to work and what's not. But measuring the context and understanding how it influences implementation effectiveness, it is we think the path forward. We don't want to be designing programs and strategies for one place, right? We need to increase our efficiency, understand how we can rapidly move evidence from these phase 3 trials to broad implementation and dissemination, and what pieces we can do broadly and what pieces need to be tailored. So by understanding prioritization across contexts, we can identify promising implementation strategies that may be broadly recommended, and I save the tailoring for where it's really necessary. So these are some of the early lessons from 001. We think some of the strengths of the work that we've been able to do collaboratively. We've been thinking a lot about where we could go from here. There's so much work in the long-acting injectable space, very limited implementation, but a lot of work there, a lot of work thinking about, okay, those who are already virally suppressed, they're doing well on oral treatment, but what about those who are non-virally suppressed? Could we be looking at studies to test strategies for scaling up injectables for those who are non-virally suppressed nationally? Wen provided a very good example from LA yesterday in a conversation reflecting upon how local health departments, they're losing their EHE funding, and they're losing their ability to be able to implement. And so they're starting to ask for implementation scientists to come and help them figure out how to do the same amount of work with much fewer resources. And so they don't want to become the implementation scientists, but they want us to take on some of that work in terms of testing these strategies. So we think that this is a good model, and it was a good pilot to think through what we could collaboratively do going forward. So I will stop there, but thank you.
All right, please join me once again in thanking Cherie Schwartz and then before her, Debbie Humphreys in their presentations. At this time, I'm going to ask all of the presenters thus far to come and sit at the front of the podium, the front of the stage. This is a fairly uncommon place to be, but we are actually quite ahead of schedule, which means we'll have lots more time for questions and answers. And again, I'll remind the folks who are online to use the chat. There have been a couple of questions that have come through so far, but please enter questions in the Q&A function in the chat, and then I will invite Rebecca Mant up to help moderate this session.
Hi, good morning, everyone. My name is Rebecca Mant. I'm with the Division of AIDS at NIAID, and I'm the program officer for the ISCI and CHESHIRE network, which, as you saw, we've been supporting in various iterations since 2019 with the EHE initiative. I just wanted to take a moment to thank all of the incredible speakers and everyone involved in these groups, both for this excellent event and for all of their work that we've seen in building capacity in HIV implementation science. I'm really delighted that NIAID was able to host this event at a time when this field is really being lifted up as a priority area across NIH, including at our institute. So I'm going to turn it over to my close collaborator for this program, Dr. Chris Gordon at NIMH, who will be moderating the Q&A. A quick note for our online folks, please do feel free to use the Q&A function on Teams to post your questions. There'll be folks who can respond to those in writing, and we'll also be potentially taking some of those to answer in the room as well. So I know that you've just heard a lot to take in, but I think, clearly these resources are here for the field, and I hope that you're all thinking about how they, questions about how they may be able to support your work, or questions about what you've heard. So thank you, and I'll turn it over to Chris.
Hi, everyone, and welcome again. Chris Gordon from NIMH, and I think I'm going to be nominally moderating this, although I hope that there are some questions from the audience to help generate discussion. I'm happy to start with one, which was, so this is, and maybe especially for those online, because it was such a rapid fire flash presentations of all the opportunities to access the resources at the hubs. These are 24 institutional awards. And so maybe as one example, there was, and I forget which hub and which presenter, there was a really cool idea about consulting with a communication specialist for dissemination. And I realized that some of these resources and activities are kind of newer and being rolled out. So I suppose it's a two-part question, which is, it's kind of like, who is eligible to access that resource? And so, one could imagine that you might triage it to, especially for someone who's doing a federally funded research project, but if someone is an implementer who wants to learn more about that service, is that appropriate, or a community member? And so I'm just wondering, as you're sort of laying out, the capacity that you have, kind of what your expected reach is for being able to provide services. So maybe whomever is responsible for that first service could speak to it. Yep. And then maybe others could chime in about just sort of how broadly they are able to provide the resources from their hubs. Thanks.
So that was me. So yeah, to be on the spot. So originally when we wrote these grants, it was intended on basically our awards that were sort of assigned to us by NIH. Obviously, I think that there's some flexibility in that. What we'd like to have, though, are projects that are sort of have evidence-based, strong evidence base. And if that is the case, sort of research that has recently been done, and then they're looking to disseminate that, I think they should just get in touch with us, and if we can make it work, we would make it work.
I'll just add, across Cheshire, ISCI and the hubs, there is a lot of interest in identifying these evidence-based strategies and working with the developers to do packaging. And so primarily so far, and Nanette in her presentation showed the example of the pharmacy prep implementation package that we worked with the developer to create. Primarily so far, we've identified those best practices through the systematic reviews that we've been doing, but we do hope in the next year or so to onboard a way that somebody might be able to reach out or deposit a publication showing that they tested a strategy, and we would go through and do our evidence quality review using the best practices framework that Ginger McKay developed. And when it meets the threshold of being a best practice, then supporting those developers and doing some packaging. And then obviously you've heard about the great resources the hubs have as well that are focused on packaging for the EHE funded projects, and then the dissemination support. So I think that is something we hope to make available to people who have reached that threshold of publishing something that shows that there's evidence for the support of that implementation strategy. As it relates to like pre-award support, we have that form that folks can fill out to request help. The QR code was in the slides. It's on the HIV implementation, HIVimpsci.org website. And then, we will be prioritizing folks who are working on a proposal for federal funding to NIH, maybe to CDC, a SPINS project, for example, if someone's applying for one of those and would like a consultation, and then we'll, assign them to the hub. So I think if interested, fill out the form and we'll all, I think this is a group that always tries to do the best they can to serve as many people as possible.
And just to add, I think that's also an area for the pre-award support that we're kind of like anyone we welcome to come to us, particularly for our hub. That's one of the things that we're focusing on and would love to explore as we have our community engagement and really our community co-leaders available to even convene consultations, conversation hours with community members who are interested as well. And how do I form partnerships? How do I get to know others in this space? So community partners as well as investigators who are either new to this as early career. And I also think that we've talked a lot about those who are more senior level and are trying to get into this space of implementation science as well.
And just mentioning that we share the tool that is publicly available. So it would be anyone, and we are very happy to also make other services available broadly. If we run into capacity limits, I am sure this group will gather and have discussions about how to handle those.